I'm not a doctor. I am an Admiral, though, with the United States Public Health Service. I'm a retired nurse and been with the federal government for 33 years, but I retired in 2016 as a Rear Admiral in the U.S. Public Health Service. I am from the Fort McDowell Yavapai Nation here in Arizona, and so it's a pleasure to be here with the conference, and this is my first time here with this particular conference, so the first speaker was very good, and I know our speakers here, who I will be introducing here shortly, and they'll be providing their presentations. Then we'll have a Q&A session just like we did with the prior speaker. So welcome everybody to Arizona. Normally it is hot, but for some reason it got all cool on us and it rained. So now it's all fresh and we watered all the plants, right? We need that for our hot summers. So welcome everybody. First I'd like to introduce, there he is. We have Dr. Phuoc Le. He is currently the Associate Professor of Medicine and Pediatrics at University of California, San Francisco, and Assistant Professor of Public Health at UC Berkeley. He is the Director of the Interdisciplinary MPH Program at UC Berkeley School of Public Health. Dr. Le completed a combined residency in internal medicine, pediatrics, and global health equity at Harvard's Brigham and Women's Hospital and Massachusetts General Hospital. During residency, he worked with Partnerships in Health to provide equitable health care in Rwanda, Malawi, and post-earthquake Haiti. He has co-founded the nation's first global health, hospital medicine fellowship, and the HEAL initiative. I'd like to welcome Dr. Le.
Thank you.
Okay. Here I see. Go forward.
Thank you so much, and good morning. And thank you so much, Dr. Beard, for that really incredible keynote, and I really hope you keep the Twitter traffic up. That seems like that it's making a big impact. And I'd love to hear the loop close about that professor, by the way. Just maybe later you can tell me the rest of the story. Well, I'm so thankful to the Beyond Flexner Alliance to allow me to be here and share some thoughts with you about the HEAL initiative. Also, I want to tell you that I really miss Fitz quite a bit. He was my advisor for years, since before we started the HEAL initiative in 2015, and he definitely is dearly missed by me and many, many others in this room. My name is Phuoc Le. My pronouns are he, him. And if you would like to connect with me online after this presentation, my email is there. So feel free. I know these presentations are very short, and I'd love to have deeper conversations with you if you're interested. I'm definitely not by myself in terms of this presentation. The people who built these slides and do the day-to-day work of running a large fellowship are pictured here. Actually, one of them, Dr. Adrian Begay, drove down from Gallup, New Mexico to be with us today. So it definitely takes a large village to run a health equity fellowship. So what is HEAL? HEAL stands for Health, Equity, Action, and Leadership. It's a 2-year, full-time, immersive global health equity training program that really focuses on the structural, political, and I would add, geopolitical determinants of health, because our fellowship is, some people might call it global local. I just call it global because the US is on the globe after all. And so our partnerships in Navajo Nation are certainly a core and central part of this Global Health Equity Fellowship. The way it started is that during the work that we and others did, many others did in Haiti after the earthquake, we saw many problems in terms of educating the global health workforce from the global north, such as the US, and the rest of the workforce in the global south or low and middle income countries. That is, this model of parachuting or white savior or missions work is so predominant. That's one problem. People coming to places that are very, very foreign to them, whether they're coming from an urban setting in the global north, coming to Haiti, or whether they're in an urban setting in the US and going to a rural setting in the US, such as on a rural reservation. And then when those partnerships form, there are very few and far between opportunities for local health professionals to really increase their skills and take leadership positions. So HEAL was formed in 2015 to really address all of these. And you'll see in our model that the experience in Haiti that we had really impacted the way that we are running the program. And you'll see that it truly is a program that's really focused on addressing these core problems in global health equity. Our mission is transformation through community, and transforming that community of fellows and alumni. And we want our fellows to dedicate their lives to underserved care, and that's what we're seeing 7 years on. Here are our core values, and I hope that everybody here would agree to these values that we formed together in the early days of HEAL. Health equity, clearly cultural humility rather than cultural competency. The value of solidarity practice and praxis, which we'll talk about later. The value of responding to structural violence, the violence that happens to our patients, day-to-day patients, because of these forces that are beyond people's control. Those top reasons that Dr. Beard said that are not actually written in the textbooks. Transforming through community, and of course, the work, like I said, being everywhere, here, internationally, wherever it may be. And then something that might be a little bit controversial, which is relentless incrementalism. We all, of course, want revolution. We want to tear down the system and rebuild it from the ground up. But at the same time, like one of my mentors who sadly recently passed, Dr. Paul Farmer, has said many times, we have to have pragmatic solidarity, which is, for us at HEAL, we call that relentless incrementalism, working towards improvement in small steps with the people while trying to advocate and agitate for a complete revolution in the way that the healthcare system is set up here in the US and in many of the LMICs that we work in. Here's our theory of change. First step is to bring a very diverse group of people together. Diversity in race, diversity in socioeconomic status, diversity in lived experience. And so that, and the way that we have structurally forced that to happen is that half of our fellows come from the communities where we work. So a quarter of our fellows are from the Navajo Nation, born and raised. Another quarter are from LMICs, and you'll see a map of where our fellows are from. So fully 70% of our fellows are BIPOC, and over 50% are URM, which is underrepresented in medicine. The next step of this theory of change is to add these components that I'm sure you are all very immersed in yourselves: mentorship and accompaniment, a strong curriculum, skills, of course, hard skills. We offer a Master's of Public Health degree during the fellowship, this community of practice and praxis, which I'll talk about later, and an immersive 2-year fellowship where almost 0% of the time is spent at the quote-unquote mothership in San Francisco. 95% of the time is spent actually day-to-day caring for patients and being a student of these structural determinants of health. And the outcome is, as you see here, a lifetime of work and impact and improved quality of care. For the sake of time, I'm going to skip over a couple of these slides. Here's a picture of one of our early cohorts. This is where we work. We have a long-term partnership in Navajo Nation at 5 5 hospitals and primary care settings, and also multiple countries around the globe, all of which are rural in nature, and many serve indigenous or tribal populations. So here's the impact so far. Almost 2 million patients served over these past 5 years by our fellows in 9 countries. And one example is of that service and this solidarity and the praxis, and something we call the ministry of showing up, just being there with the people, is March in 2020, during one of the darkest periods of the COVID pandemic in Navajo Nation, where the per capita Navajo rate in Navajo Nation was the highest in the country. And during that time, we had 52 fellows and alumni on the ground working in those 5 facilities. And because of our strong relationships and partnerships there, we were able to bring several dozen additional volunteers from UCSF. And you remember that time, many of the large academic centers were idle because everything was shut down, all the elective surgeries were canceled, and so there was a really pent-up desire and goodwill from clinicians, nurses, doctors, and others at UCSF. And we were able to see patients in the motels and hotels where they were being housed during quarantine and isolation. And we did that for several months, which to this day, it has strengthened our partnership with the Navajo people. And here's the community of practice and praxis. This is what we are cultivating during the fellowship and beyond. So many of our alumni are still actively involved, and our leaders, including Dr. Begay, who's sitting in the back of the room, graduated from the fellowship and is now a senior leader in the HEAL initiative. This is a snapshot of a subset of our fellows. We're now 160 strong. And with that, I'll say thank you. I'll look forward to having a discussion with you all. And again, feel free to connect with me outside. Thank you.
Thank you, Doctor. Well, you know, on the presentation, it's really interesting to see the involvement of his organization as working with the Navajo Nation. I mentioned the tribe I am from, and it's here locally. Navajo Nation is one of the largest tribes in the United States, and there are actually 574 federally recognized tribes in 48 states. So I mentioned that I worked for Indian Health Service, and when I worked in headquarters, which is located in Rockville, Maryland, we would travel throughout the nation, meeting with as many tribes as we can. But I'm happy to hear about the involvement that Dr. Lay had mentioned, and it's a pleasure to hear that. And also with Native Americans, they do have the option, which Navajo Nation has done, as well as my tribe, which they can administer their own healthcare program. They receive the federal funding, but also look for outside funding, plus do third-party billing in order to provide services to their people. So I just wanted to mention that as I sprinkle in a little bit information about that I know. The next presenter is Dr. Greg Chadwick. He is the Dean of the East Carolina University School of Dental Medicine and has served as Dean since 2012. Formerly, he served as Associate Vice Chancellor for Oral Health at ECU, where he led the effort to establish the dental school. Dr. Chadwick is a native of North Carolina, received his bachelor's in business administration from the University of North Carolina at Chapel Hill. After graduating from UNC School of Dentistry, he practiced general dentistry in community health centers. Entering a residency in endodontics, he earned an MS in endodontics from the UNC School of Dentistry and subsequently practiced endodontics in his hometown of Charlotte for almost 30 years. He is a former president of numerous dental organizations, including the North Carolina Dental Society and the American Dental Association, and he currently serves as the president-elect of the FDI World Dental Federation. Please help me welcome Dr. Chadwick.
Thank you. It's a privilege to be here with you and to share some of the things that we've been doing at East Carolina. Obviously, in 15 or 20 minutes, I can just hit the highlights, but I look forward to the discussions afterwards. As we started down this journey some 12, 15 years ago, we began to look at some of the challenges in North Carolina, and those are the things that we've been talking about here for the last day, and Beyond Flexner has been talking about for the last 5 or 10 years. As we look at North Carolina, though, I want to point out the map, but the greenish area, those are the urban areas. We're a state of 100 counties, 22 of them are urban. The definition, 250 people per square mile would be urban or more. And when you look at the rural areas, we have 78 rural counties, and they go from the east to the west. And I'll show you a map of where we are located. But these are just some of the challenges that that we recognize, and certainly the social determinants of health, and as we heard yesterday, certainly some of the political determinants of health. But I'd also like to add the commercial determinants of health, not just the third-party payers, but I'm talking about the sugar industry, the fast foods industry. That's a huge challenge in our state and certainly in this country, but certainly in the in the rural areas. As we start with looking at our mission, one of the key phrases in there is develop leaders. We look in, as we're selecting students, we look at leadership. We look at their passion to serve in rural and underserved areas. But we're really developing leaders, and along the way, we want to make them become dentists. We want to help them become dentists to practice in North Carolina and serve in the rural and underserved areas. We look at our school as a school that has a dual mission. It's educating the next generation of providers, but also providing a significant amount of care in rural and or underserved areas of our state. Some of the drivers of our mission are ones that you're very, very familiar with. Certainly advancing healthcare equity, certainly social mission, social determinants of health, as we've already mentioned. But I want to emphasize the bottom two there especially. Our role in dentistry is being part of primary care. If we're in rural and underserved areas of our country, of North Carolina, we have to be part of primary care. We have to be working with the primary care network. We have to be practicing and working interprofessionally. There's no simple list of what we do. When you look at our mission, it's certainly much broader than just the words that are on the page. When you look at the vision, when you look at the core values, but it all boils down into the community needs and our ECU model, which I want to talk with you a few minutes about, and then our mission, and then the ECU model. It all works together. It's just one system working together to address community needs. Thank you. I just wanted to point out the physical facilities that we have, and I was hoping there'd be a pointer here, but I don't see one. But if you look at the lower central, that's the dental school. This is the health sciences campus. We're part of the university system. We have 16 higher education campuses. UNC, North Carolina State, UNC Charlotte, and East Carolina are the top, are the largest four. We have 29,000 students. We're on the western campus, which is the health sciences campus, and in the bottom there, with the circle, you see the School of Dental Medicine. Right next to it is Allied Health and Nursing, and then up in the upper left is the School of Medicine. They've just recently received funding, and they're going to be coming down very much closer to us, kind of where that parking lot is, just above the dental school. But the point is, we have a wonderful opportunity. Everybody focused on primary care for rural and underserved areas of North Carolina, and we have the opportunity to educate and to learn and to work interprofessionally. When I talk about the School of Dental Medicine, I put this slide in because this is the School of Dental Medicine. It's not just the building in Greenville. not just the dental school, if you will, in Ross Hall, but it's all of our community service learning centers. We have 8 community service learning centers across the country, across the state, excuse me. And dental school, as you know, is 4 years. Each of these community service learning centers are full-service dental practices. We have about 12 faculty and staff in those locations. We have 4 senior dental students at any one time, and our class size is 52. So each student, we have 5 rotations, if you will, during the senior year, and each student rotates to 3 of the community service learning centers. In order to select the right students to go to East Carolina University for a dental education, we focus primarily on North Carolina residents. We spend a lot of time with pipeline programs because we want to know the students during the time that they're matriculating up to going to dental school. So we start back in high school with some of our pipeline programs, and I'll show you a visual of a couple of those. But we want to know those students during the time that they are coming out of high school, hopefully in college, but by the time they get to the application process, we want to know who they are. In that application process, we use a holistic admissions process. Certainly, we look at DATs, we look at grades to get them to the point that we say, yes, this student is qualified and this student is a possibility. But we're really looking for students that care about our mission, that are going to help contribute to the mission of the School of Dental Medicine and actually make a difference in the state of North Carolina in addressing some of the health inequities that we have in our state. Of those programs, the pipeline programs, we have one that's a 3-day program that's been very successful. This program actually occurs in Ross Hall, in Greenville, and you can see over the years the number of students that we've had participate in that, a little over 490 students, but 16% of those have actually become students or are students at our school, and another 29, or about 5%, have gone to other dental schools. So that program is really successful, with about 20% of the students going to dental school. Then we have kind of a weekend program. This is one of the programs that we concentrate on for high school students. This occurs out in the community service learning centers or out in a private dental office. And one of the programs, which is really kind of neat, that the students get into it because it's high energy, hands-on, preparing tomorrow's dentists, dental CSI. So they look at models of teeth and they look at images and they match those up pretty much forensically, but it gets them involved in some of the things that we as dentists do, pouring up impressions, looking at those impressions, and gets them engaged and lets us have an opportunity to meet them. As we look at achieving our mission, certainly diversity is extremely important to us. North Carolina is a state with 33% underrepresented minorities. When you look at the dotted line, the orange line there, that's the number of minority practitioners we have, dentists we have in North Carolina, and the green line are the national numbers. So we have a pretty steep hill to climb, in that we would love for our students and our faculty to be representative of the people of North Carolina. And you can see by the purple line, this last year, we were at 38%. We'd like to continue that. I'm afraid next year, by looking at the admissions numbers, it may go down just a little bit, but we're probably averaging about 25 to 30%. If we expect our students to go out into rural and underserved areas and practice dentistry, keeping that student debt low is extremely important. There are dental schools where students will graduate $400,000+ in debt. There's no way you're going to a rural, underserved county in North Carolina with modest Medicaid and be able to have a successful practice and retire that debt. Our average debt has been below $125,000 a year for the first 7 years, and that bottom line, you can see the national average is a little under 300,000. This is the state of North Carolina. These are where our community service learning centers are. You can see the crest on the East Coast. which is our school in Greenville. And as I said, we have 8 community service learning centers across the state. I also mentioned that we need to be part of primary care. This, to me, is the gold standard. This is Ahoskie, North Carolina, very, very rural area. On the left, you will see Roanoke-Chowan Community Health Center. This is a 38,000 square foot primary care facility. They even have a rural residency program there now. On the right, you see our community service learning center. And as I said, we have 12 staff plus a couple faculty at each of those sites. The faculty and the staff live in those sites. When you go to the westernmost site, it's about 5.5, 6 hours away from Greenville. And the 2 in the east, or the 3 in the east, are 3 to 4 hours away from us. Each one of those community service learning centers has an advisory board, which is extremely important in keeping us grounded, keeping us being part of the community. And as I said, the community service learning centers are full service dental practice, not just safety net clinics, not just emergency clinics, but we offer the full range of general dental procedures because that's where our students are 60% of their senior year. One of the questions we always ask, well, how successful are you? Where are your students staying? And as I said, dental school is 4 years, but many of our students will go on and do a residency for a year afterwards. Many of them do a general practice residency. Some of them become specialists. But of those students that are out in practice, that have graduated, have completed their training, 90% of them are practicing in 65 North Carolina counties. And you can see where those 65 North Carolina counties are, all across the state of North Carolina. Until just very recently, we've seen about 86,700 or so patients. That's a particularly important metric to us because 30% of those are Medicaid patients. Many of those patients would not have been seen had it not been for our dental school. And this plays to that other half of our mission, educating the next generation, but also providing a significant amount of care to rural and underserved areas. Somebody recently asked me, you say approximately 30%. Is that like 25% or no? No, it's actually 30.8%. We underestimated it just a little bit, but it's about 30%. So where are we going in the future? What are the opportunities? Well, we want to use those community service learning centers as kind of hubs, not only as education hubs, but as community hubs, practice hubs. We look at school-based programs, and I'll show you a couple slides in just a few minutes of some of the activities that we have centering out of. And I'm going to use Ahoskie here in the first example with the school-based program. And if you look on the right, you'll see the purple county there, when it says Hertford, that's where Ahoskie is located. We're right below Virginia, and there are 3 counties that surround Ahoskie. This is a school-based program in Bertie County. This is the county just south of Ahoskie, between Greenville and Ahoskie. And our PI on that program is Wanda Wright, and Wanda's here in the audience in case any of you have questions about that program. But she started a school-based program where they're seeing every school child in that county over the next couple years. And if that continues, and it looks like it's going to be sustainable, we should be able to pretty well eliminate a lot of the decay in that county. If it's sustainable, we can do it in that county. We can replicate that. We can scale that to other counties. As a matter of fact, Wanda's already started another county in Jones County to the south of us. 95, or I think it says 92% of the school kids in that county are on free lunch. That gives you an idea of the economics in that county. Veteran Smiles, we talked about veterans yesterday. In one of the breakouts, we have volunteer programs where we, at 2 of our community service learning center, are providing care on a volunteer basis, like a mom or a Mission of Mercy type program. However, the VA and other volunteer groups have actually provided funding to be able to sustain that. So if we extract somebody's teeth on that day, we can take impressions, and the funding will continue at the student rate, so we're able to break even on it and to complete the care for that veteran, and it's working very, very well. Teledentistry is another thing that we're using to connect our community service learning centers, because there's a general practice model. out in the community service learning centers. All of our faculty are general dentists, but this gives them a consultation service, a live consultation service, virtually with some of the specialists. On the left, you see Paul Lindau, our endodontist, actually helping to find canals and show somebody out in a hosky where the canals are in a tooth so they could do a root canal. Hyde County is another project that we've just started. Matter of fact, we'll start seeing our first patient on April the 8th. This is one of those counties that doesn't have a dentist, doesn't have a physician. They have a PA that comes in on occasion. We wanted to establish a relationship out there because that was one of the counties when we were building our school. The people in that county went out and signed a petition. We had over 2,000 signatures of why we needed this dental school, and we carried that around in our pockets as we were talking to the legislature. So we really wanted to do something for Hyde County, and we're starting this clinic. It'll be 1 day a week to begin with. We'll take residents and students out there and provide care. But equally importantly, it gives them an opportunity to be able to call us at the dental school if they have an emergency, and we can make an appointment for them to come in and see us. I'd be remiss as I talk to legislators. Each one of these community service learning centers provides $1 million to $1.5 million of economic impact in each one of these sites. That's huge when you're looking at the county being able to realize something, not only just the improved health care, but the people in that county, we're 12 staff. We're hiring local people, and our faculty, as I said, are living out in those communities. So with that, I'll stop and look forward to answering questions and maybe having some discussion a little bit later. Thank you.
Great, thank you, Dr. Chadwick. Dental and Indian Health Service is also an area that does not get enough funding from Congress. They appropriate funds for Indian Health Service, which also the tribes receive that funding. So tribal leaders are constantly, every year, advocating for more funds. But because of programs like they all are presenting, these are things that definitely tribes are wanting to take advantage of because they're running their own programs now. So they now need to become the experts instead of relying on the federal government, who normally is the one who provides that service. So it's good to hear all of this activity that's happening out there, and encourage everybody to participate in it as well. Our last panelist is Dr. Gary Cloud. He is Vice President, University Partnerships at A.T. Still University. Dr. Cloud is a community health zealot. He is blessed to work with the Health Professions University dedicated to preparing healers for underserved communities. Dr. Cloud works with health centers, associations, leaders in the movement, and leadership at A.T. Still University to identify workforce needs and establish innovative health professions, colleges, partnerships, programs, and strategies. Help me welcome Dr. Cloud.
Thank you. When ATSU was starting its second medical school, on the first day of the first class, very innovatively, the faculty had taken about a 12-foot long piece of butcher paper and cut it into strange shapes. Basically, they were puzzle pieces, and they gave each student one of those puzzle pieces. The student didn't know it was a puzzle, and they gave them 2 crayons. And they told the students that the purpose of this puzzle, or the purpose of this piece of paper, was for them to draw something to introduce themselves to the class. And one student came up, and he had this piece of paper. It's about this big, and on it he had a boat. I think maybe it was a green boat with green people in it and one brown person. It had a squiggly line that looked like this, and it had a very detailed fish. And when it came time for him to describe his piece of paper, he said, well, my family was escaping from Vietnam, and they were going to be killed as the Viet Cong were coming in, the North Vietnamese were coming in. But a very nice man came over in a boat and took my family and took us out to a big ship. And we ended up in the U.S. on the east coast of Texas, a squiggly line there. And my family fishes for this kind of a fish. It's a village of mostly folks from my village who like to fish for this certain kind of fish that he had drawn so specifically. He said, in our community, we have a community health center, and there's some very nice people there who want to do the right thing. But some of the healers there don't really understand the culture of my people. And so when they give instructions or when they're failing to listen well, my people get turned off and don't want to be part of that. And so my goal is to become a physician who goes back and works within my village, because I will understand how to speak well to my people. I'm blessed to work at A.T. Still University, as you heard, a place that's committed to preparing healers for underserved communities. And more specifically, let's talk about the history of that. In the 90s, the Arizona Community Health Center Association invited now what's called A.T. Still University to partner. And on top of that, then they eventually asked for a PA school, and then in the national level, they asked for a medical school, and then they asked for a dental school, have that in reverse, a dental school, then a medical school, and then a dental school. All in all, there have been now 2 colleges, 2 medical schools, 2 PA schools, 2 dental schools, and other colleges and departments within A.T. Still that are committed to this community health center world. All of this since the 90s, right? So, and it wasn't, here's what happened. The health centers would ask for these places, then they would help design these places, and then they would engage in helping train the students in these places. Now, this takes tremendous leadership, so I need to point out that I work with a lot of really cool people who have a commitment to the underserved. You'll see them all over the place here at this conference from A.T. Still University. But I need to point out the president who you've met, if Dr. Phelps will stand up, if he will stand up, raise his hand at least, okay, because not only does he enable this to happen, I just talked about the opening of 6 colleges in a 20-something year period. Not only does he enable it to happen, he requires it of us to happen. And he also needs to have Dr. Wendell stand up. Stand up, Dr. Wendell. All right. Dr. Wendell is an expert at accreditation, and to accredit all of those programs I just talked about, you need an expert, and he may well be the nation's expert, having helped accredit or take the lead on accrediting each of those programs there. Right, so not only are these 7 colleges now in existence with a commitment to preparing healers for underserved communities, and very specifically for their partners in the community health center world, but there's of course a lot of strategies that involve in supporting that. And I want to talk about 2. So to get to those 2, I need to tell a couple of stories though. So in the design of the second medical school, as we had the health centers gathered together, a physician of a health center in Louisiana named Dr. Wiltz, Gary Wiltz, he said, I need to tell a couple of stories. And so here's his 2 stories. He said, one, in the health professions, we understand that unfortunately it is mostly privileged kids who get into health professions school. Sometimes it's on purpose, but often it's things like this. Becoming a health professional is really, really hard. You could describe it as like climbing a really steep canyon wall. And maybe there's some cracks in that canyon wall, and you can get a finger hold and you can start going up, but you don't know when you grab it if you're going to catch a piece of that crack that actually it goes down after a little bit. And those are things like, who was your hero in 4th grade? Because very often, but not always, very often somebody's hero in 4th grade is the person whose profession that they want to follow. And say in 5th or 6th grade, they start thinking, wow, I could be a dentist if my friend was a dentist. And that doesn't mean if if the most important person in your community was a drug dealer, that you couldn't become a dentist, but man, your chances just went down. That was maybe one of those cracks if you were following the wrong person. Or how'd you do in 4th grade math? Because statistically, those who don't do well in 4th grade math rarely do good in 6th grade science. Those who do good in 6th grade science rarely get into health professions school. And it doesn't mean if you came home with your homework in 4th grade there and said, Mom, I don't understand this math, and she says, well, neither do I, but I never used it, so I wouldn't worry about it. Doesn't mean that your chances that you can't become a physician assistant, but man, your chances just went way down. So there's a lot of those cracks, said Gary, right? His point was, it's so often it is the privileged who get into health profession school. He said the other story I need to tell you about is that underserved communities, and all community health centers are underserved communities, base issue is a brain drain. All right, let's look at a normal curve here, right? Normal curve of society. Out on the edge, you got rich people and poor people. In the middle, you have most everybody else, right? Educated, uneducated, but most are in the middle. Young, old, but most are in the middle. When a society loses its educated, wealthy, working-age folks, it doesn't have the social infrastructure to support itself. And so around the world and in the U.S., when we have an underserved community, it has to do with the brain drain. All right, so Dr. Wilt said, let me put these two things together for you here. Say, twice in my life, I've had Girl Scouts come through my health center. These were about a decade apart. And I thought, boy, these girls have the heart of a healer. I'm gonna give them the privilege, the advantages. And so we brought them into the health center. The health center sort of raised them, and like in 4th grade, he was their hero. One of them was struggling with math, and so he got a tutor for that individual. And they both did good in 6th grade science. And in junior high, he talked to him about having children and how that was going to impact the time that they had to go to medical school. And it came time for them to go to school. And here's a really interesting part of the profession we're part of, right? There's this part where people who are from the school have an in. Right, so he said, I went to Tulane, so I called up my friends at Tulane and said, hey, would you make sure that these guys get an interview? And they both got an interview, and the health center was ecstatic because they both got accepted. In each case, 10 years apart, they held going-away parties. Congratulations, you've been accepted to medical school. He said, but they were gone 7 years, and they started dating. And they got married and had kids, and they never came back to Franklin, Louisiana. And Franklin, Louisiana is not a better place today because 2 little girls became physicians. Franklin, Louisiana is a worse place today because if they would have stayed here, they would have been the mayor or the PTA director. And I became part of the brain drain. And as you start new schools at AT Still, you need to move away from this ivory tower idea. Because if you're going to be a school that brings people to you and convinces them that they shouldn't go back where they came from, and they're coming from an underserved community, you will not be making the underserved communities better. You'll be making the underserved communities worse. You need to figure out a strategy for infusing talent into communities instead of stealing talent from communities. All right, now I'm ready to talk about just two of the many strategies that are ATSU. One of them we call Hometown Scholars, and in that one we ask the nation's health centers, 14,000 strong clinics anyway, 14,000 clinics for 1,400 health centers. We ask them to tell us who ought to be going to school, who ought to be tomorrow's physician, dentist, physician assistant, and other things that ATSU has, along that whole pipeline or pathway strategy that you heard talking about. But also we have a strategy of infusing talent into communities by moving to learning in place. So each new program we've started has a stronger version of this learning in place with the intent of infusing talent into communities. Today, there are under contract 49 community health centers from Hawaii to New York where we have miniature schools going on, where some piece of the education but not just a rotation through, where the students are embedded and are part of that. And if you tie those two together, these health centers then are in a position to say, here are the students in our community who have the right heart to come back and serve, and they're going to stay right here and learn for a piece of, eventually, we hope, for all of their education. We hope that we can move there. And if I can give some advice to this group, let me suggest what we can learn out of those two stories. One, we really need to move to daring children to dream from underserved communities. We have to get away from the idea that it's the privileged only who get into health profession school. And especially when we couple that with traditional education, because it's those privileged then who are coming and practicing on the poor and leaving and going back to their communities when they're done, and that's a moral issue, right? One, We need to dare children to dream and raise them up into the health professions from underserved communities. 2, we need to figure out strategies to infuse talent into underserved communities. If not, we're in the position of stealing it from underserved communities and not making them better off, making them worse off. Thank you, guys.
Well, we'll go on to the Q&A portion of the panel discussion. So we have someone right over here.
Hello.
Yes,
Can everyone hear me?
can hear you.
Okay, great. Hi, everyone. My name is Rashmi Krishnasamy, and I'm with the Beyond Flexner Alliance. I was the one who was Vanna Whiting on stage yesterday during the Macy Awards. So this question is for, I guess, everyone who is here. First of all, thank you so much for your wonderful presentations and all the work that you've been doing. This is so incredibly important, and I'm really glad to hear that at the institutional level, there's change happening. So a little bit about myself. I am an aspiring physician, and I've been having some really wonderful conversations over the last couple of days with my fellow students and learners. I know, Dr. Cloud, you just kind of captured this beautiful quote of, keeping people dreaming, or daring people to dream, right? My question is kind of, how do we keep people dreaming when they're in these institutions? So a little level set. I know we talked a little bit about just how dental school admissions look, but as someone who's trying to go into medicine, every year the AAMC data shows that we have 50,000 applicants on average. 25,000 of those are white folks. Less than 100 people every year are Native American or American Indian. Around 4,000 are Black, and around 3,000 are Hispanic or Latinx. So, and the cost of applying to medical school ranges between $5,000 to $7,000. With the intergenerational wealth gap in this country that has transcended generations, right? How can we expect people who are in the underserved communities to want to dream in the first place? And then let's say they do dream and they get a seat at the table. These institutions, right? We have all these hidden barriers once you're in medical school. You gotta pay $300 for a stethoscope. You gotta pay $600 for a sketchy. You gotta ace all of your exams and then also make time to study for boards and then do well on the boards and then match and then do all that fun stuff. So how do we as institutions and leaders within institutions minimize some of the hidden barriers that may not be talked about? Of course, there's holistic admissions that we do before, but there are a lot of hidden barriers to even getting to the holistic admissions that is often overlooked. And then there are a lot of hidden barriers within the institutions, even just as simple as, I know Dr. Kenya Beard talked about microaggressions within institutions amongst faculty, but that also translates to students. So how do we expect students who have dreamt, and have gotten there, to keep dreaming and not get burnt out? And then how do we protect student efforts while they're there trying to combat this? I talked to a bunch of students yesterday that were saying that to combat burnout, they organize and advocate, but oftentimes because of the power structures that exist within the institutions, they don't feel supported, and they have to give it up. But if we have folks that are burnt out coming into the profession and then are burnt out in the profession, how do we expect them to be rested and quality healers? So any ideas for addressing the hidden barriers and keep people dreaming would be really much appreciated.
All pointing. Dr.
I'll
Cloud.
try. Wait, obviously, there's going to be many strategies to make sense here. I think one important one is we need a workforce in the universities that are reflective of the students that we wish to attract, and are therefore, in a better position to be culturally proficient and welcoming to those students.
Go ahead.
I would say another way to address those barriers, first of all, we need to have role models out there. We need to have our graduates out there. Our graduates can speak in an entirely different way than I can speak, or the administration of the school. But when we have our graduates out there, especially, and I'm calling them pipeline, pipeline programs, when we have gatherings of pre-dental or pre-dental students, is have people that are representative of whatever group that we're speaking to there. And to have our students there when we have the in-house programs in, in Greenville. They're primarily run by the students. I mean, we have faculty there that are managing and all that, but the students are the ones that are interacting, with the students to be able to speak their, to be able to speak their language. But I think you're exactly right. You can't solve a problem until you've addressed, the barriers. And I think that's where we need to concentrate, is addressing those barriers, and that's what we try to do during the admissions process, during the holistic admissions process, is when somebody comes to the interview, most of those people are known, because if we've been doing our job, we know who they are and we know their background before they come in on interview day.
Thank you. Great question, really complex, and happy to chat with you after the session as well. You mentioned the hidden, and I teach a lot at the undergrad level about the hidden curriculum. It truly is, there's a formal and informal, and then there's the hidden curriculum. And as somebody who is the first in my family, first gen, to go to college and medical school, I definitely did not know there was a hidden curriculum. And that's something we need to really disseminate, is knowledge to the faculty, knowledge to staff, that there are things that we don't teach that are part of the selection process that you can't just get unless somebody has told you, and that's right. That somebody means that if you have that somebody, that means you have some sort of privilege or that environment. So we have to really disseminate knowledge about the hidden curriculum and account for that in the holistic interview process. There are certain things that are already happening. We're getting rid of MCATs. Like, some schools are not doing admissions based on MCAT, and Step 1 scores, USMLE scores are now pass, no pass. Things like that are going to help. And so many medical schools now, for success in medical school, they've gone away from grades, such as at UCSF, it's pass, no pass throughout, which are small steps. So the other thing that I wanted to address, and I try to go away from the term pipeline. I try to think about pathway, because pipeline is a metaphor that is problematic in our country. But there are these leaks. You have, even though there are 100 AIAN identified applicants every year to medical school, at the end of the pathway, which is at the dean level, there's 1 or 2 in the entire country who are AIN identified. So somewhere along the way, whether it's medical school, residency, fellowship, faculty, then to the dean, senior level, there's drips, there's leakiness that people, because of many, many things, maybe part of it is the hidden curriculum, maybe it's stereotype threat, maybe it's microaggressions. It's an environment that is not inclusive. And we talk about DEI, the inclusivity, the inclusion part, I think, is a huge barrier to retention of minority or URM in medicine, and I would suspect across the health professions. So, as leaders come in, as we focus on the D and the E, we have to really, really focus on the I, and we're a long way from there. How do we make people who are self-identified as from a oppressed community, oppressed identity, feel like they are included and belongs? Now it's DEIB, B for belonging. So, sorry for the long-winded answer, but it's a very complex issue, of course.
Thank you so much. Thank you for that answer. Really quickly, shameless plug for Student Assembly. We're going to be talking about a lot of this stuff for all the students in the audience from 6 to 8 p.m. tonight in the Ellis Room. And also, if anyone is curious about some of these barriers that I talked about, poster 23, I did research on this, so happy to chat. But thank you, gentlemen, for your answer.
Great, thank you. We have another question over here.
I'm sorry. My name is Marie Grady, and I'm with the Ohio Association in Columbus, Ohio, and we're the local PCA. how do we move this needle of underserved to underrepresented? So I grew up in the inner city, as they consider the underserved. But I had two parents. They raised us. We went to Catholic school. They worked so hard to send us to Christian schools. But I'm still lumped into, because I grew up in the inner city, I'm underserved. How do we get away from that? Because in the inner city, it's such a rich culture, and I think we take that away, that we don't have mentors and family, things that uplift us. It's taken away by seeing underserved, and it's underserved because there's resources not given to them on purpose. So how do we touch? I know admissions are trying to touch on it, but how do you need to get to legislators that are preventing these resources? There's redlining. There's so much things still going on and prevalent. There's a neighborhood in Columbus, Ohio, that they still have redlining that is across the street from considered an inner city or underserved area. How do you move that needle and say underrepresented versus always underserved? Because you're lumping me into the category of underserved because I live in the inner city. So how do we move that and change that narrative?
I'll take a shot. We at HEAL, we use resource denied, because it doesn't, the term resource denied to me means that something has happened to a community that's beyond their control. They're denied something that is their human right, for example, healthcare, or other resources, housing, safety, right? Food, all of these things that are resources that should be bestowed on communities, but yet have been denied to these communities. Sometimes because of a failure of a trust relationship, such as in the 574 federally recognized tribes. Sometimes it's because of redlining, like where I live in South Berkeley. It's a redlined area, and I'm a gentrifier, So we use that for sure. And then what we teach in HEAL is the asset-focused approach rather than a deficit. Even though they're resource denied, this community that we're working in, we focus on the assets that they have, which are, if you just open your eyes and do an asset map for every community, there are tremendous riches of people and human capital and community partnerships, strength, culture, religion, history. All of those things are assets that when you're developing programs, you need to partner with, rather than saying, what is wrong with a community? Ask yourself, what is strong within the community first?
Yeah, we got some good advice. We got good advice yesterday to take the political path, but that is saying, I think you guys should do something different. And we got good advice today to take the personal path. Like, it starts with you. What are you going to do to change that?
Just one comment that strikes me as I look at the communities where we are. We didn't go into a community and say, this is a community where we need to be. We talked to people in the community, and the question was, what do you need? And as we talked to the people in the community about what do you need, was that something we were able to work with? Was that something we were able to put together? And I mentioned at each one of our community service learning centers, which are in 8 rural areas of North Carolina, we depend on our advisory board to keep us grounded. We ask the advisory board, are we addressing the problems of the community? Are we addressing the things that you need to have addressed? Because we want to be in those communities. We want to be part of those communities. But when I'm talking about we, I'm also talking about our students, because each one of those students is living out in each one of those areas for 9 weeks at a time. They wake up there, they go to the grocery store, they walk around town, they meet people, they talk to the neighbors. They're becoming part of those communities, and they are seeing for themselves what those communities need, and is this something that I'm able to provide? And part of that inspiration is that we want some of those folks to be able to stay in those communities. We've got, for example, in Northampton County, I keep referring to Ahoskie as the quintessential community service learning center, but it was our first. But this one just happens to be, Northampton County is the county right next to Ahoskie. A young lady came to dental school, and we asked her, what do you want to do after dental school? She says, I want to go back and serve the people that raised me, and that was in Northampton County. Came to dental school. She did a residency after dental school. She did a rotation at Ahoskie. Went and did a residency in Ahoskie, and then went back to the county next door and practiced. She is now our assistant director in that area. So it's creating those role models, bringing value to those, bringing value to those communities.
Excellent. Okay, great, thank you. Looks like we have a question here in the center too.
I thought I'd come up a little bit earlier so that I didn't make everyone late by my late question, but thank you very much for your presentation. Scott Oliger, I'm a family physician and a residency faculty in Northern California. I had a question. This is my 4th Beyond Flexner assembly that I've been to, and I'm always impressed by, the sort of centers of learning that are here being represented. Dr. Lee, I also trained at UCSF, but I started my career in a rural community and then came back to teach at an urban residency, and now I'm back up in a rural setting again. And the one thing that I notice is that I think there's a need to decentralize some of the initiatives. The last speaker talked about these community learning service centers, which I think is one of those things, but when I'm here, I notice that, like community participant research, there's a lot of complaints from communities that researchers show up, do their research and go away. They never share their research. They never discuss that, and a lot of the community members never really think that's what should be looked at or studied. It feels the same way sometimes for this, that we need to somehow branch out to some of the urgently needed rural settings that are critically underserved, regardless of whether they're people of color or not. We're losing hospitals, health centers, et cetera, and so it would be interesting in the future that the main centers come out to the areas like where I've worked and bring people in and make them part of the process, because I think that's part of the solution. We talk about, elements of, youngins from those communities becoming healthcare providers, but in the community where I am, which is a community of 9 smaller tribal entities, you see no tribal providers. When you research their schools and their participation in schools or their avenues or mentors, there are none. And so I really think there's a huge urgency, in the next 10 years or even faster to kind of deliver some of these, branding issues out to the rural areas. Thank you for your answers.
Good comment.
I couldn't agree more. And we mentioned the community service learning centers, but we're looking at those. I think we're looking at those as being, out in the rural areas. But I see it even, diversifying even further, going out even further. And I would use Wanda Wright, as I mentioned in the comments. Wanda's here today. Wanda's also our associate dean or assistant dean for diversity, equity, and inclusion. In the project, when she's going out, she's going out to the grassroots. But not only is her group taking care of the oral health, taking care of prevention, but they have so many more opportunities to make relationships out in those communities, make relationships with the school board, make relationships with folks in the community, and begin to build kind of a healthcare community around in this particular area where we have a federally qualified health center. We got the dental school there as well, but we're out in the counties 30, 40, 50 miles from there, diversifying even further, getting out into the really the grassroots areas.
Okay, thank you. We have another question?
First of all, thank you for your presentations and thank you for your work, really. And I think having been longtime fans, I think, of all of your programs, you're such demonstrations of what happens when you truly embed education in communities and in honest community partnership. But I think that the reality remains that you are the exception and not the rule. And if we want to think about how do we make you the model of all education, how do we move that forward? And one of the things, again, having had an opportunity to site visit AT Still maybe about 8 to 10 years ago and talked to each one of you, I know that you have made your programs work despite the incentives, the structures, the policies, the funding that push most programs in a very different direction. And I wonder if you could advise us as a community who has the opportunity to organize around advocacy. If you had that magic wand and you could change a structure or a policy around you, either that is helping you do your work or making it harder to do your work, what would that be? And normally I would probably give you 3 to 5, but for the sake of time, if you could give us a top one.
Sure. Thank you. Well, thank you so much, Candace. I know in your career you've done a lot of advocacy work, and were seminal in the creation of the Teaching Health Center model. So thank you for that. And I think we're hearing about the Teaching Health Center model, which is fantastic. Yeah, I mean, for me, nobody during my residency training and my medical school training, nobody taught me advocacy. Nobody said to me, hey, you got to follow the money, find the trail, and that's where you point your finger and press and make an impact there, because that's how all of this runs. Whether it's here or whether it's in rural Malawi or Rwanda or Lesotho, it's how do you make an impact on how money flows. And one of my other mentors, Jim Kim, a physician, that's why he chose to go to the World Bank, is he knew that with that leverage over financial policy, he could make a real huge impact. And many of us that go into medicine, of course, we understand that finances are the big deal, but we're never really taught and how to advocate for more resources, and how to actually maybe redistribute some of the resources that are out there that are in the for-profit or late-stage capitalistic space, and put that towards a social mission. And I can get into details, but HEAL does that. We compete in the marketplace, and we redistribute those funds for a social purpose, a social mission. And that's how we fund our program. We don't actually get federal funding or state funding, or we get support from UCSF, but the majority of our funding does come from this competition that's in the market and open. But what we've done is taken $20 million in the last 7 years from basically out of the hands of Wall Street and into a social purpose, and without having to compete with other nonprofits for a meager bit of philanthropy that's out there. So now we're moving a little bit more into the advocacy space, and I think for scale, for bringing more into resource-denied settings, we really have to turn to our political leaders, and it sounds like Greg is doing that in North Carolina very, very well. But on the federal level, we're having conversations, and I've never been taught how to do this either, with congressional staffers, and just saying, how can you take a look at what HEAL's done, and how can we bring more resources from the federal government into communities, not just for HEAL, of course, but for training programs like so many of us are doing, so that we don't have to literally plan year by year because we haven't gotten Mackenzie Scott money, or we're literally not planning because of our philanthropic cycle, which is an annual cycle. So magic wand, of course, is money, if that's your question. But I think for me, if we can all learn how to be advocates to our policymakers, because we're already all experts, we just need to be able to speak the language of policymakers.
Candace, I love your question, because that's what we've all got to be. That's what we're doing here, is advocacy. It speaks to, as I go back to when we're talking with applicants, we're looking for leadership. It goes back to the leadership piece of our mission. Just being a dentist is not enough. You've got to be a caring servant, leader, dentist in order for us to accomplish everything that we want to accomplish. We select people that have that passion for service, that have the values. And if we enable them to become leaders, if we give them those skills that they need, if the communities that they're practicing in, if they go back to practice in a rural or an under-resourced area, they will be our advocates. They will be our ambassadors going out there. So to me, it's the graduates. It's the people that have graduated, that have those leadership skills, that are out, that can talk about the prevention, can talk about the healthcare pieces, but it's also those people that can make the relationships in the community that we need to make in order to let people know how important oral health is and how important health is and what an important part oral health is of general health to make sure, in fact, that we are healthy. But to me, it goes back to leadership, and the chief skill of the leader is advocacy for our cause.
So a lot of what we're talking about at the conference, including at this session, is about change. Change is challenging paradigms. Paradigms are held in place by processes and cultures. So how do you move folks from loving their process, say an accrediting body or a licensing agency, or this is how we do it as faculty within a university? How do you move folks from loving their process? You do it by getting them focused on the purpose. And so I think that's the real question is, how do you focus on purpose? There's a lot of ways that we do it at ATSU. One of them is with these various colleges having community campuses with students embedded. We're approaching 900, I think, students embedded in health centers living there across the country for their education. Is that we ask those health centers to tell us what to do. We hold ourselves accountable. So the idea is when this administration is gone from the university, will it stick with its purpose? One of the ways that we hope it will stick with its purpose is that the schools are dependent on these community campuses, and those community campuses have their own committee that has really the ability to shut that school down or put it in crisis by saying we're cutting off your clinical training or this much of your education. For instance, the second medical school we built has students for a year here in Arizona, but for 3 years with faculty and content delivered locally, the students are there. So 3/4 of the school are somewhere else, and those are folks that have a lot of power. So I think that for me the base answer is, how do we get all of us to begin to think of purpose and not to be in love with our processes?
Okay, any more questions? Just some of my thoughts on a couple of these issues or questions that were brought up is, one is you need to get involved with your community and know your political leaders. I'll just bring up the example of my tribal leadership. I'm on the health board. And there, when issues come up like the funding, and they plan federal funding 2 years, 3 years out. So you need to be aware of what's currently in appropriations, but also what's planned for next year and also the following year. So it's usually a 3-year process. I bring that up because it is part of the system that we work in, especially if you're looking at grants or funding. I don't know what their grants or the funding that they receive, but also there's nonprofit funding partnerships. So I'm just saying, if you see there's a need in your community, find out who your political leaders, especially if they're healthcare people who are elected into those positions, they would understand it quickly and be aware of what they can do. And maybe they have connections where they could send you to school X or this other organization, but takes a lot of planning and a lot of coordination. So I'm sure there's people, individuals here, not only here with the panel, but everyone out there where you have those connections. So I think you really need to see, where can I start in my community? So I know people don't like to get political, but there's a time when you need to get involved. If communities committees make recommendations to the political people, like in my case, tribal leaders, you need to be on that board, because that's why they set you up for, is to make sure that you are the eyes and ears of the community. So I'm just encouraging you to get involved in different ways, not just, thinking of, well, nothing's going to change. Well, if you want things to change, you have to be at the table, or you need to know somebody at the table. So just wanted to encourage that to everybody. So I think that's the end of our panel discussion. So I want to thank all three doctors for being here. Yes.